Welcome to AETCM, the emergency medicine channel. So shall we start? So a patient came with, a patient was brought to the ER with one-sided weakness and slurring of speech. So the patient was taken into the ER and starting with the primary survey.
At this point, I mean, at least tell the age and gender, no?
Okay, sir. Yeah, 70-year-old male.
Okay.
A 70-year-old male with one-sided weakness and slurring of speech.
Good.
Came to the emergency. Starting with the primary survey, patient was having a patent airway. There were no any pooling of secretions in the airway, and he was.
One thing is that once you're saying the initial symptom, no, say the duration also, like one-sided weakness since what time?
One-sided weakness since the last 1 hour. Sir.
1 hour. Okay, that means a lot, no?
Yes.
In our assessment and further planning. So, 74-year-old male presenting with one-sided weakness.
Yes.
Now you move on to the next things. Yeah.
Patient one-sided weakness since both one-sided weakness and slurring of speech started since last 1 hour. Acute onset of weakness. So the airway was patent, and then the breathing was respiratory rate was 18 per minute, and saturation was 99% at room air. Equal raise in the chest, bilateral equal raise in the chest. And coming to the circulation component, heart rate was 80 per minute, and BP was 220 by 110 mmHg. At this point, two large bore IV cannulas were put in place, blood samples were taken, and for continuing with the further assessment, disability wise, GCS was E4 V5 M6. Right sided upper limb power was 0 by 5, right sided lower limb was 0 by 5, and pupils were bilaterally equal and reactive to light. Next, coming to the exposure part, patient was febrile and GRBS was 110. So we have a patient with, in the primary survey, summarizing the primary survey, there is a patient with high BP with one-sided weakness, with complete weakness of one-sided weakness. So coming to the adjuncts.
You told slurring of speech.
And slurring of speech, yes. Coming to the adjuncts.
But he was making sense of what you were saying.
Yes, sir. He was conscious oriented. He was not in altered state.
Okay.
Next, taking the blood gas, and there is no acid-base disorder in the blood gas, and sodium was 137 and glucose was also 110. So at this point, ECG was also taken. In ECG, it was showing sinus rhythm with left ventricular hypertrophy changes. So in the initial assessment, we seen that a case with high BP and one-sided weakness with slurring of speech. So as it is an acute onset, a decision of getting a radio imaging was taken to do a plain CT initial. Because initially we decided to get a plain CT and we shifted the patient for the CT.
Okay. So at this point, is there any other information you would like to have?
What are the comorbidities, what medication, and events leading to this situation, like what?
Like, can you elaborate on it? Like,
so the patient is has no any history of any allergies, and comorbidities are type 2 diabetes mellitus, hypertension and dyslipidemia. Diabetes mellitus for the last 8 years and hypertension for the last 6 years. On OHS, diabetes on OHS, and hypertension is taking ACE inhibitors. So the morning he was having his breakfast. At that time, suddenly he had developed the acute onset of right-sided weakness of upper limb and lower limb. He was not able to grasp the food which he was eating, and then when he was talking, he was slurring of speech. So the patient was brought to the emergency room.
Okay. What are the differentials you are going to consider at this point for a patient who has presented with one-sided weakness?
Such patient, like we have to rule out the stroke mimics, like seizure.
First a stroke for sure, both thrombotic and hemorrhagic, and then the differentials for stroke. What all things?
Like it can be transient paralysis post seizure.
Here definitely we don't have a.
The history wise, we don't have an event leading to that. Okay. Or the patient can, a hypoglycemic event can also be presenting with weakness.
Unilateral weakness. Okay.
Next, another. As a differentials, there can be a brain mass, space occupying lesion.
Okay. Any structural issues in the brain?
Issues can be there, and
hemiplegic migraine.
Good. migraine with aura.
Known case of the having
Okay.
such presentation.
Then
In such patient,
here one more thing, no? With high BP.
yes.
What is press? Encephalopathy syndrome. Again, it can present with unilateral weakness, no? Then any other place other than the brain?
In the heart, we rule out arrhythmias, but that eventually causing the stroke itself.
Broad. Once you think about broad differentials for stroke, always rule out spinal cord, high spinal cord issues also. Okay. Then
So then psychiatrical reason,
what is
conversion
Melas?
disorder. See?
Melas. MELAS. Heard about it? I mean, for discussion's sake, okay. There is something called as mitochondrial encephalopathy with lactic acidosis and stroke-like symptoms. So again, anyone presenting with lactic acidosis with stroke kind of symptoms, always think about rare causes also. Okay. Okay. Then SDH. Other hemorrhages in the brain, no?
Yes, sir.
Okay. Other than the intraparenchymal kind of things, you need to think about those things. Okay. So the differentials for stroke or stroke mimics is huge.
Yes.
Okay. So before jumping into a definitive diagnosis of stroke, always think about other things also. Okay. This patient, if he had similar episodes in the past, then as he told, it could be secondary to migraine and things like that. So always think about other differentials also. So here, I think a reasonable choice is to go ahead with a CT at this point. Okay. So you asked for a CT.
Yes.
Okay, fine. Then
Sir,
did you try to intervene for the BP at this point or not?
no, sir, because as we have no idea whether it's an ischemic or hemorrhagic, like considering to be a test stroke initially, ischemic or hemorrhagic, we did not take control
Okay.
of it.
Are there any situations where you know that it is a stroke? It could be hemorrhagic or ischemic, but your BP is high. Before the CT, you would like to control it. Is there
The
any
patients, there's a gradual progression of this loss of weakness. If it's increasing with time, then we can consider it to be like an ongoing hemorrhagic or the
the patient is in heart failure? Okay. Where
Aortic
there are
dissection.
aortic dissection, things like that. Where there are other pressing indications where you feel that reducing the BP is more important, you are justified in controlling the BP. It is not that it is a golden rule that we have to maintain BP above or 200 and all in acute strokes. Okay, so always think about other causes where that might overwhelm the acute stroke itself. Okay, like you told aortic dissection. What else? One more thing we told. Aortic dissection and heart failure kind of symptoms. Okay, fine.
recent. So once the CT plain brain was sent, there was no any hyperdense lesion seen, so we ruled out bleed. And no and bleed. CT has no bleed, so we went with the categorizing the and by NIHS's criteria scoring, we scored the patient. The score came around 9 because both upper limb and lower limb no movements with slurring of speech mild to moderate. So a decision of thrombolysis was taken.
Okay.
But when decision of thrombolysis was taken,
Okay.
we
So
need
just
to
one question at this point. Was it a CT plain or CT with angiogram?
CT plain brain.
CT brain plain was done. Okay. Fine. Yeah,
CT
continue.
plain brain
Yeah.
only was done.
Yeah.
At this point, we consider recombinant plasminogen activator thrombolysis to use it.
Okay.
So before using that, as the BP is on the higher side of 220 by 110, we had given labetalol 10 mg initial dose to reduce the BP. And as it wasn't reducing for this case also, we started the infusion of 2 mg per minute. And once the BP had come below 180 range, then thrombolysis has been started.
Okay. Okay. So labetalol, how do you ideally start labetalol?
Labetalol usually start dose of in this case, as in like in stroke, which is going for thrombolysis, 2 doses of 10 mg's can be given, followed by starting the infusion of 10 mg 1 to 2 mg per minute.
Okay. Always give the boluses for acute control. Okay. Your infusions are it's more like a maintenance kind of thing. Okay. The acute control you always try to attain with multiple boluses. 10 mg, you can repeat it every 5 to 10 minutes. The only thing you need to look at is the heart rate. Okay, and most of the time it should be
comorbidities
okay.
of COPD and the beta blockers.
Once there is an option of giving labetalol, give multiple doses, IV boluses, try to get it under control. Once it is under control, then you start on the IV infusion. The problem with labetalol is that there is a ceiling dose. How much you can give in 24 hours? 300. So if you are starting at 2 mg per hour,
2 mg per minute.
2 mg per minute, sorry.
Yes,
You are giving 120 mg per minute. Technically, you are reaching the ceiling dose within less than 3 hours. Okay. So always give a bolus dose. Then probably we will be able to start with a smaller infusions. Okay, fine.
Apart from the labetalol, we can start with nicardipine infusion or clevidipine infusion.
You don't have them, no?
We don't. Yes. After such attaining the BP control, thrombolysis has been initiated. We go ahead with 10% will be given as bolus, and 90% will be 10% will be given over 10 minutes, and 90% will be given over 1 hour.
Okay.
0.9 into body weight will be taken for calculating the amount of the recombinant plasminogen activator dosage. During after giving this thrombolysis also, we should continuously monitor the BP monitoring. Within the first 1 hour, every 15 minutes BP will be monitored. Next 2 hours, half an hourly. After that 2 hours hourly, and then every hourly BP monitoring has to be monitored, so that if in case it's within the 24 hours, after the first 24 hours of the thrombolysis, BP should be maintained below 180.
180 diastolic?
Diastolic 180 and 190.
105.
180 and 105.
So it is 185, 110. And once your pre-thrombolysis target is 185, 110. And post-thrombolysis target is 180, 105. Less than that. Okay.
In this patient, after the first CT has been done and thrombolysis has been planned, post 6 hours, we went ahead with another imaging, MRI plus MR angio, to see the size of the infarct and the vessels, regarding any occlusion or anything in the vessels. So in that report, we had a left-sided infarct, left MCA territory infarct we had, and at the M2 level there was a occlusion. So this patient was furtherly evaluated with a stroke medicine, and then they decided to do DSA, digital subtraction angiography, and as there was a clot there, they planned for stenting.
Mechanical thrombectomy or stenting?
Stenting they planned. In this case, they did stent.
Okay. So what are the usual BP targets? Can you just enumerate once more? Like if you are not planning for thrombolysis, what is the target?
Not planning for thrombolysis, it should be less than 220, 110.
Okay.
If you are planning for thrombolysis, before giving the thrombolysis only, you should get the BP less than 180 by 110.
Okay.
And duration.
Fine. Then any other drugs other than your
Labetalol.
No. For thrombolysis, you are giving drug. Any other drugs in acute stroke you have to give?
I mean, if we are not thrombolizing, then we can give a loading dose of aspirin, clopidogrel, and atorvastatin. But if you are thrombolizing, you should not give them.
Theoretically, it is aspirin alone. Okay. For acute stroke, a patient who is not on antiplatelets, only aspirin and statins are enough. Okay. And BP control. There is a role of, if they are definitely going to be bedridden or decreased mobility, then your heparin.
Heparin.
Okay. Subcutaneous for DVT prophylaxis heparin. So it will be aspirin, heparin, and statin for sure. Okay, and BP control. That will be your usual line of management. Okay. So here you told that you are going ahead with a CT. How will you choose imaging in stroke?
As per the guidelines, like as soon as we reach the patient, the radio imaging should be done within 20 minutes, and the injection which we are planning, if like an ischemic stroke, it should be done within 60 minutes. So in that view, a plain CT would be sufficient. But if we are in a tertiary care hospital who can do thrombectomy immediately, so we can go with CT plus CT angio. So we can even have the vessel identification. If there's a big thrombus, instead of thrombolizing the patient can be directly taken for a thrombectomy. And even if you thrombolize within the first 4 hours, thrombectomy can be planned within the 6 hours duration also. So after thrombolysis, we can repeat the CT, angio or MR angio for the vessels, and they can take up for thrombectomy.
Okay. So the key thing is, what is the window period in stroke?
4.5 hours.
So any patient within 4.5 hours, your primary aim is to see whether he's a candidate for IV thrombolysis. Okay, for that CT is more than enough. So you get a plain CT, rule out a bleed, thrombolize. Thing comes in between 4.5 to 6 hours. Okay, so there your IV thrombolysis window is gone, but there is a window for
mechanical
thrombectomy. So again there is an extended window of 24 hours for proximal occlusions. Okay, so 4.5 hours to 24 hours. That is where you will need a vessel imaging upfront.
Yes.
Okay, in those kind of situations, you are justified in going ahead with a CT plus CT angiogram or an MR with MR angiogram to know about the vessels. So we have something called as a TOF imaging also, right? So that again, the intracranial vessels, you can get a kind of an idea about the vessels also. Okay, so that's how you choose what imaging you need. So the answer will be, it depends upon the institutional capabilities and protocol. Okay, most of the centers, there may not be options for interventional stroke kind of things. So once we have those kind of interventions, then definitely after your 4.5 hour kind of a window, there is a definitive indication for vascular imaging also. Okay, then.
Sir, then considering like the pre-hospital stroke scales, regarding the emergency medicine technicians, the ambulance patients, ambulance services who are bringing such patients, we can use the FAST criteria.
Okay.
Like face, arm, speech, and time. Like if anyone is identified, they can pre-alert us that such a patient. Or the other criteria are Cincinnati pre-hospital score criteria, where also they also use the facial droop, arm drift, and speech as the parameters. So it helps us to select the radio imaging choice as soon as the patient arrives, so that we will not have any delay in the history part.
Okay.
Apart from that, the stroke can have symptoms like traditional symptoms and non-traditional symptoms. Traditional symptoms usually can be the focal neurological deficits like the weaknesses, dysarthria, aphasia, kind of things. Non-traditional symptoms would be like more like altered mental state, shortness of breath, dysphagia, such symptoms which are rare, but these also can be considered as the symptoms of this stroke.
Okay.
Stroke mimics, we had discussed about it. And regarding the ABCs, like of the airway breathing circulation for a stroke patient, on initial when they approach to the hospital, we need to protect the airway, considering a patient can aspirate if he vomits. So if
Not
there's
only vomiting, anything else with stroke and swallowing?
there is a weakness in the palatal muscles and that he cannot
So swallowing is a major concern, no? So depending upon the area of territory of the stroke, your swallowing might be affected. So that itself warrants an awareness regarding aspiration. Okay.
We should take care of that. And BP reduction. Management wise, if we consider it to be an hemorrhagic kind of a stroke, where when we take the CT plane when there is a bleed, then in that cases we need to, the management will be changed, like reducing the ICP pressure. For that we need to target, and if there is any herniation, mannitol, such a kind of other line of management.
We won't go into hemorrhagic for now. We'll stick to thrombotic.
And then indications and the contraindications for the recombinant tissue plasminogen activator. Indications wise, if there is a score of NIHs greater than 5, we usually we consider for thrombolysis.
Okay.
And the patient has in plain CT there is no bleed, no features of bleed, and we know the exact time of onset of this stroke. We should not consider wake-up strokes also as at stage 3 less than 4.5 hours. When we know the initial point of pain, time when the stroke started and it's less than 4.5 hours, then only we can go ahead with the thrombolysis.
Okay.
And regarding the contraindications, first initial contraindication would be BP more than 185. And if the patient had any major surgery to the brain within the last 6 months, or if the patient is is on the drugs like heparin, warfarin, or in which PT and PTNR and APTT are deranged, it will be a contraindication. At the same time, if the patient has
GA bleed.
GI bleed. GI, other than the head bleed, anywhere the other bleeds, 3 months they mentioned. If it's only head bleed, 6 months was mentioned.
Then,
Major contraindication.
okay. You want to talk about anything else? Now you have a patient whom you have thrombolized, like there's a drop in sensorium after say 12 hours.
After thrombolysis, yes.
What thing you need to consider and how will you approach?
In such a case, initial we need to rule out if there is any IC bleed causing the drop in sensorium. At the same time, we need to go check for all the vital monitors, ABCD, again checking for any breathing compromise, circulatory compromise, or even GRBS should be tightly maintained. It should not be either hypo or hyperglycemia.
Okay. What is malignant transformation of stroke? Basically, it is a hemorrhagic transformation of large strokes. That usually use the term of malignant transformation. So there, irrespective of the primary issue, even if it is thrombotic, you have to manage it as a bleed kind of thing. You have to probably the patient will need a decompressive craniectomy, because at that point our concern is the racing ICP, and you need to take on measures which will decrease the ICP. So most likely intervention is going to be decompressive craniectomy, where you are going to the neurosurgeon goes in and remove a part of your skull and allow the brain to expand and pressure is taken care. That will be the immediate next step. Okay. Then anything else we missed? Workup, stroke.
So workup in this stroke, we can causes of the stroke, TOAST classification, like what is the cause, we can work it upon it. If it is a cardiac, we need to do the echo and the carotid Doppler to see if there is any emboli or the thrombus which is leading into the ischemic strokes, or any arrhythmia which is throwing the emboli of such kind of situation, if you consider.
You'll usually need a 24-hour heart rate monitoring. You will need a Holter to look for any arrhythmias. Then
the other
young stroke workup, anything?
Autoimmune,
and even prothrombotic states have to be evaluated.
Okay, fine. Anything else? A bit? No. Right. Okay, thank you.